the teaching hospital of Harvard University. It was a photo from the neck down of a prepubescent girl wearing a white cotton bra and underwear. An 11-year-old girl was admitted to the hospital with a 104-degree fever and a rash, said Castleman. This was a Castleman case, a stump the expert extravaganza for Harvard physicians in training. Later, a summary would be published in the New England Journal of Medicine. Castleman continued with the girl's story. The patient was well until 6 days before admission, after a camping trip on the north coast of Boston with other Girl Scouts. Ticks were found on several of her companions, all of whom remained well. None were seen on the patient. He said that over the next 15 months, anorexia occurred, with a daily rise of temperature as high as 103 degrees Fahrenheit, a pinprick rash all over her body, muscle tenderness, and a weight loss of 11 pounds. 3 days before admission, the girl complained of aches in the knees and elbow and a shaking chill. 2 days before hospital admission, her temperature rose to 104 degrees Fahrenheit, and there were small, flat red spots over her ankles and soles of her feet. She complained of a mild frontal headache, and the evening before she was admitted, she vomited. Tests for rheumatoid factors and lupus were negative. He then ceded the floor to Dr. Richard Masters, a young assistant dermatologist who was the discussant in the hot seat of this session. Masters nervously moved to the front and looked out over a room full of medical professionals in white coats, observed from the walls by framed portraits of distinguished Harvard clinicians. He told them that the blood tests showed anemia, a mildly low white blood count, and low chloride. This was counter to what was typically seen in a severe bacterial infection. Masters cleared his throat and continued. I come back to the exposure to ticks. Although Rocky Mountain spotted fever is indigenous in the Cape Cod area, including Marthas Vineyard and Nantucket, the frequency of the disease has increased over the years. He added that spotted fever is spread by ticks and occasionally by airborne particles. So what is your diagnosis, Dr. Masters? Said Castleman. Masters cleared his throat and said, spotted fever and juvenile rheumatoid arthritis in remission. Next, Dr. Stanley Robboy, a young pathologist, took the floor. In Castleman's world, pathologists, the seekers of truth who find wisdom through the lenses of a microscope, had the final word. A microscopic image of a biopsied rash pustule from the girl's foot filled the screen. Robboy showed several slides of cross-sectioned blood vessels in the skin, and then stated, the microscopical examination disclosed a marked lymphocytic infiltrate that cuffed almost every blood vessel in the papillary and reticular dermis. A large artery in the subcutaneous dermis was occluded by an organizing thrombus, and neutrophils were scattered throughout the muscular wall. More simply, the cells that lined the girl's blood vessels were massively infected with Rickettsia bacteria. Damaged vessels began leaking blood into various parts of her body, the skin, the lungs, and the brain. As blood began clotting in the fine capillaries of her brain, she experienced headache, a stiff neck, and sensitivity to light. Without treatment, she could experience convulsions, followed by a coma and perhaps even death. Robboy agreed. It was spotted fever, despite the fact that the antibody blood tests and cultures of the blood, cerebrospinal fluid, and skin were all negative for the disease. The patient was started on intravenously administered tetracycline therapy shortly after the biopsy. 2 days later, she was discharged, Robboy said. Another physician chimed in about an unusual aspect of the case. At the time of admission, there was considerable discussion about the fact that Rocky Mountain spotted fever had only been reported south of Boston, in the vicinity of Cape Cod Islands. This was the first warning flare sent up by one of the most respected medical centers in the nation about the unusual outbreak of Rocky Mountain spotted fever. This version of spotted fever didn't show up on standard tests, so there were probably many undocumented cases. A year and a half later, the CDC issued a limited distribution memo about a worrisome spike in Rocky Mountain spotted fever cases on the southeastern end of Long Island. In 1974, there were 20 cases, compared to only 5 in 1972. Then, in 1976, Suffolk County on Long Island set a new record for spotted fever: 40 confirmed cases and 4 deaths. In April alone, the island's state health department